Hello and welcome to another emergency question and answers for families in intensive care and intensive care at home. I want to welcome you to another show. You're welcome to ask any questions here or talk to me directly. You can type your questions into the chat pad, or you can connect with me directly here on StreamYard just by clicking on the StreamYard link that I just posted in the chat pad. Hi Helen, nice to see you again. I hope you're well. So yeah, type your questions into the chat pad or connect with me live on StreamYard if you want to. Before I go into today's questions that have come in during the week, what makes me qualified to answer questions for families in intensive care and intensive care at home? My name is Patrick Hutzel. I am a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and where I've been consulting and advocating for families in intensive care since 2013. And I can very confidently say that we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com. You can see what our clients are saying there, or you can verify it on our intensivecarehotline.com podcast, where we've done some client interviews. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are currently sending our intensive care nurses into the home for long-term ventilated adults and children with tracheostomies, and also for home BiPAP, home CPAP, for tracheostomies without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions. We're providing palliative care at home as well. We're providing ventilation weaning as well at home. We're providing port management, Hickman's line management, PICC line management, as well as central line management at home. With Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. And we employ hundreds of years of critical care nursing experience combined in the community. No other service provider brings that high level of skill in the community than we do. We are actually the only service provider in Australia that is accredited for intensive care at home nursing. No other service provider has achieved that high level of accreditation. We're also NDIS approved, TAC and WorkSafe in Victoria, ICARE in New South Wales, and IISQ in Queensland, DVA all around Australia, and like I said, NDIS all around Australia. Okay. We'll be going for an hour. We'll be going for the next hour roughly. And, you know, the floor is open for you to ask questions here or connect with me live. If not, I just want to start actually with a testimonial today that I just received this today, actually. This was a client we worked with in the last few months. And cutting a long story short, one of our clients' sister was in ICU with a cardiac arrest and supposedly a hypoxic brain injury. And the ICU team was adamant from day one that they should withdraw life support because it wouldn't be, quote unquote, in the best interest for this particular patient to live, right? And they were saying, oh yeah, she's going to die anyway, and it won't take long, and blah, blah, blah. And they said, if she was going to survive, she won't have any quote unquote quality of life. And they wanted to push a DNR, they wanted to push hospice and withdrawal of treatment. You know, cutting a long story short, we were helping the family to advocate for a tracheostomy, for prolongation of treatment, making sure she was getting all the right treatments, you know, physical therapy, exercise therapy, not doing a PEG tube, which was critical in this situation. Because what have I been saying for many years here, that especially for our clients in the US, whenever you have a family member in intensive care and they want to do a trach and a PEG, do not give consent to a PEG. And this case study today once again illustrates why this is so important. So had this family been giving in and given consent to a PEG, which the ICU was pushing once they realized this patient is actually not dying, and once they realized that the family won't take no for an answer, right? That's when, you know, they were trying to push a PEG tube, and the family refused, obviously under our guidance and under our advice. And, you know, patient was improving, and, you know, they were making headways with patient weaning off the ventilator, really kicking goals, getting out of bed, getting mobilized, you know, starting to eat and drink, eventually being weaned off the ventilator completely, then moving towards decannulation, having the tracheostomy removed. And then eventually the tracheostomy got removed, and then she went home. Now, put that into contrast with either end of life, or put that into contrast with going to an LTAC. You know, we have helped so many families now to keep their loved ones in the right environment, right, and getting good outcomes. So let me read out the email that I've gotten from this particular client. Hi Patrick, sorry I haven't gotten back to you sooner. Things had gotten very intense and I needed a break for my health and peace of mind. My sister was discharged to home a week ago last Friday, just a few days short of a 2-month stay. So this all happened within 2 months. But the family was told for the first few weeks their family member is going to die. And if they were to survive, they won't have any quality of life. Keep that in mind. Okay, now let's keep reading the email. She asked to do outpatient rehabilitation and has moved back in her apartment. She's able to walk while holding onto someone's arm, and she is now speaking clearly. Her memory and focus are greatly impaired. She has a memory gap of many years, but is still slowly remembering things. The hospital has not gotten her into speech therapy until the end of January. I will be sending you some detailed reports, as I'm sure you probably want to know what transpired with medical details. Yes, we absolutely would love to know what's happened. See, things were touch and go as Dr., I'm not going to mention names, decided on her own that my sister was decisional, and though she and my siblings had talked my sister into a PEG, fortunately my sister backed out of it and said no. I think that PEG was scheduled at least 3 times with a constant threat of that or comfort care. I give great credit to you and your team for giving me the guidance to help her alive and stand up to the egregious pressure from the hospital staff and my siblings. I will be writing you soon with a more detailed summary. Of course, I'm willing to provide you with any info I can, so others might learn from my experience. No one should ever have to go through this and kind of hell when their loved one is sick. Well, thank you so much, Cassandra, for sending this through. It's been a great pleasure working with you and your sister, and it's been, you know, another success story for you, and it's been a great success story for us, and it just goes to show what is possible if you know what questions to ask, if you know what to look for, if you know what to advocate for, you know. And what is critical here is always that you know what questions to ask, which we can help you with, and also get access to the medical records. I can't stress enough how important it is to get access to the medical records, because without access to the medical records, it's almost like flying blind, and you can't afford to fly blind in situations when you have a loved one critically ill in intensive care. You simply can't afford to fly blind, right? Because once the family had access to the medical records, we could even more guide them and say, hey, what they're telling you is actually not what's in the medical records, or vice versa, right? You got to look out for people's actions, not for their words. Their actions speak much louder than their words, right? So, another scenario that's just come up today for me as well that I think I want to share here, and I think it's really important. So one of our other clients that we're working with all of a sudden found out that their family member had an increase in a Keppra dose. The situation is that, family has their 80-year-old father in ICU, and he is again had a hypoxic brain injury after cardiac arrest, and he's slowly, very slowly waking up, and he's had myoclonic jerks. He had seizures right from the start, but the myoclonic jerks got controlled by what we think was Keppra and also some baclofen. Things were sort of improving, and then it turns out that the ICU team increased the Keppra from 1,000 milligrams twice a day to 2,000 milligrams twice a day. And that is a hell of a lot of an increase in dosage, right? So, and the question is why? So finally, the family got access to the medical records, and we've looked through the medical records, and there's no reason documented why they've increased the Keppra from 1,000 milligrams twice a day to 2,000 milligrams twice a day, and their family member is not waking up, or is not waking up to the extent that we would like to see it. Keppra has a sedative effect, and the question is what's happened there. And it turns out that apparently the pulmonologist made the decision to increase Keppra. Well, the pulmonologist should be worrying about weaning this man off the ventilator. Increasing Keppra should be the job of a neurologist. And the family hasn't spoken to a neurologist for weeks, right? It's also very important for you when you have a family member in intensive care to understand who to talk to for different issues. Where are the specialties in intensive care? Who makes what decision? The pulmonologist should be worried about ventilation, tracheostomy. This man has a tracheostomy. That should be the pulmonologist's domain. Anything that's related to the brain, i.e., how do we manage seizures? How do we manage myoclonic jerks? That is the neurologist's domain, right? And you need to keep talking to those specialties. You shouldn't be having the pulmonologist interfering in prescribing, increasing or decreasing a Keppra dose. You shouldn't be having the neurologist involved in weaning your family member off the ventilator, right? That's the pulmonologist's domain, or the intensive care specialist's domain, right? Once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care, right? So I hope that helps you understand, more of what you need to look for when you have a family member in intensive care. Okay, so now let's look at the next question that's come in. That is actually a question from an intensive care at home inquiry from Nepal, who says, "Hey Patrick, I would like to inquire about the cost of hiring ICU equipment for home. If you could give me some costings, that would be appreciated." Nepal, it's not a simple, we can give you costing for equipment. The question is who's providing the care. If we help you organizing equipment and you want to take your family member home independently, that could be a death sentence, right? It's one thing to have equipment, it's another thing to know how to operate it, you know. So a ventilator, a home ventilator, you know, costs anywhere sort of between $15,000 to $20,000. You need a suction machine, which probably costs around $500 to $1,000. You know, bear in mind you need two of each, right? You need two of each. You need a special care bed most of the time, which is around $4,000 to $5,000. You need, you know, assuming your family member is immobile, you need a hoist, either a ceiling hoist or a portable hoist, which again probably costs around, you know, $5,000 for a portable hoist, maybe more, $10,000 for the roof, for the ceiling hoist. You know, what else you need? You might need a bedside monitor. You probably do need a bedside monitor. You know, again, costs maybe around $2,000. You know, but you also need, you know, you need other equipment depending on whether your loved one has a catheter, depending on whether they've got a PEG tube, a nasogastric tube. You know, once again, the biggest challenge for families in intensive care or intensive care at home is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care, right? So also with equipment for home, I don't know your location, Nepal. Depending on your location, you know, if you're in Australia and your family member is an NDIS participant, this should all be taken care of, right? But even if it's not taken care of and you are coming through another insurance and maybe you're in the US, I don't know. And like I said, I don't know your location. Health insurances should have an interest in paying for home care equipment, right? And the reason health insurances should have an interest in paying for home care equipment, paying for $5,000 per bed day in an ICU, $6,000 per bed day. You know, investing into home care equipment is so much more cost effective in the long run. So much more cost effective in the long run. Right? So, equipment is just a small part of what needs to happen when you take your loved one home. It's just a very small aspect of what needs to happen. Right? Okay, so then let's move on to the next question, you know, and Nepal, you can find, just before I move on to the next question, you can find more information at intensivecareathome.com. I encourage you to do a little bit of reading there and then circle back to me once you understand more about the concept of intensive care at home. You know that the equipment side of things is definitely a huge aspect of it, but everything else is a huge aspect of it too. And that is mainly the care provision, getting the critical care nurses into the home. That is probably the more important piece here. Okay, now let's read out another question that came in on the YouTube channel this week. It's from Moxnell, who says, "Hi Patrick, can a patient with 46 days on the ventilator be weaned off the ventilator? She's on BiPAP settings." Well, that's a great question, but once again, it is a very incomplete question. Why is it an incomplete question? Is she on BiPAP with a breathing tube? Is she on BiPAP with a tracheostomy? Is she on BiPAP with a mask? Right? That's the question here. And why is she on BiPAP? Right? Is she on BiPAP because she's got COPD, asthma? I don't know. And Wee Chow, hi to you as well. Wee Chow, W Chow, just left a comment there. Send your messages here, send your questions here, or connect with me live on the StreamYard link that I posted in the chat pad. Welcome to talk to me. So coming back to Moxnell's question, can a patient with 46 days on the ventilator, be weaned off the ventilator, she's on BiPAP setting. So first thing we need to map out, is she having BiPAP with a breathing tube? Is she having BiPAP with a tracheostomy? Is she having BiPAP with a mask, right? And why is she on BiPAP? Why is she on a ventilator for 46 days? What's the issue? Has she had any spontaneous breathing trials whatsoever? Right? What happens if you take the BiPAP off? You know, once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. I'll tell you what needs to go hand in hand with ventilation weaning, right? What needs to go hand in hand is mobilization, physical therapy or physiotherapy, right? Very, very good nursing care, whether that's bed washes, whether that's taking patients to a shower, mouth care, eye care, you know, cleanliness, TLC, you know, that is all part of the process of weaning someone off a ventilator. You know, it's multifactorial, multifaceted to wean someone off a ventilator, right? So I hope that helps you understand. But you know, what needs to happen to wean someone off BiPAP is you need to wean the pressure support and the PEEP. That's how you can wean the BiPAP. And what might also need to happen is they might need to do arterial blood gases as they try to go through the weaning process, right? Nothing's going to happen without going through the weaning process. So guys, when you send messages, make sure they're complete. And I know that's easier said than done, right? I mean, you are not sitting at home wondering, oh, I wonder what questions I should ask if one of my family members is going into intensive care next week. I get it. That's not how you operate, you know. But by the time you do have a family member in intensive care, you do gotta, you know, gotta do your research very, very quickly, very, very quickly, because you are in a life or death situation, and you know, you can't afford getting it wrong. You cannot afford getting it wrong. Keep that in mind. Right? Okay. Next, let's move on to the next question. No updates, no explanations. Just give me 1 second, and in the meantime, type in your questions into the chat pad. Type your questions into the chat pad or connect with me live on the StreamYard link here. I don't bite. I'm here to help you. I'm here to answer your questions. You know, I'm here to answer your questions and nothing else. Okay, so yes, another question that I had this week is from a subscriber called Cookie, who says, I'm trying to understand why my husband died in ICU from a successful heart surgery. If you're struggling with questions like that, you know, the best way for you to answer those terrible questions is for us to look at medical records, right? That is the best way to deal with situations like that, right? Unfortunately, we have to look at the medical records. Yeah, it's the best way to deal with this. But, you know, it also shows that, you know, you need to reach out much earlier than when it's too late. You know, you need to reach out when you have your family member in intensive care, not afterwards, when patients have passed away. Like I said, we have saved many lives. We have saved many lives for our clients in ICU, and that is documented and verified on our intensivecarehotline.com podcast section and on our intensivecarehotline.com testimonial section. You can read up what our clients say there. Okay, next question from Lynn. My daughter's husband is in an induced coma and has pneumonia and may not be woken tomorrow after all. I'm in despair for my daughter, who is so anxious. Okay, so sometimes when patients are in ICU with pneumonia, usually the time to wake them up is once the pneumonia has been cleared. Okay, so the questions here to ask, is why can your daughter's husband not be woken up? What's stopping your daughter's husband to be woken up? Is it the pneumonia hasn't been cleared? Is it that they're having a septic picture? Is it that, there's another pneumonia now coming from another infection source? What is the reason? Is your daughter's husband too weak to be weaned off the ventilator? Ignorance is not bliss. And you got to find out what's happening here. So once again, you need to get access to the medical records, or your daughter needs to get access to the medical records so that we can actually see why is he not woken up. Or let me talk to the doctors and nurses directly, and let's ask all the questions that need to be asked in a situation like that. Right? Have the antibiotics not worked? Is that why your daughter's husband can't be woken up? Right? And I've seen patients being intubated in an induced coma with pneumonia, sometimes for many days, sometimes for many weeks on end. What else is happening? Have they done a full head-to-toe assessment? Is the heart working? Have they done a heart ultrasound? Very, very important questions to answer here. The one of the problems here is that when a patient is being weaned off the ventilator, right, the sooner you can make that happen, the better, because there's deconditioning going on every day. Every day, patients are being deconditioned fast when they can't be weaned off a ventilator. And that is a huge concern. That is a huge concern, right? So the sooner you can wean someone off a ventilator, the better. The better recovery chances. It is a race against the clock. It is definitely a race against the clock. Because if you can't wean, your daughter's husband / son-in-law off the ventilator, he might end up with a tracheostomy. You're trying to avoid that. And don't get me wrong, a tracheostomy has its time and its place. But if you can avoid it, you absolutely should avoid it. Right? And it is absolutely a race against time. A race against time. So, before I move on to the next question, if you have any questions, type them into the chat pad or simply send them to me or simply connect with me here on StreamYard, and you can talk to me directly. Right? Talk to me directly. So, what else is there? What other questions are there while I'm going through the questions that are coming in? Just give me 1 second. There it is. This is from a subscriber called Tag, who says, "Hi Patrick, my brother is in ICU on a ventilator, unconscious with seizures for 2 weeks, but is not brain dead. Can I ask for more time to make decisions and delay end-of-life support?" I'm very sorry, Tag, to hear about your brother's situation. Now, what makes you think that intensive care teams should be rushing into end of life? What makes you think that intensive care teams should be rushing into killing your brother? Right? It's why I started today with another testimonial, because, like I said, I can confidently say we have saved many lives with our consulting and advocacy, many lives, right? So why should you be rushing or letting the intensive care team rush to stop treatment and let your brother die? Where's the urgency? Where's the rush? Where's the rush to kill someone in intensive care? Where's the urgency? Help me understand. Help me understand what's the urgency here to kill your brother. Is he an inconvenience for the intensive care team? Is it a real or is it a perceived end-of-life situation? I talk about this almost every week, but I also think it is so important for you to understand the difference between a real and a perceived end-of-life situation. And here is why. Right? Here is why. A real end-of-life situation is a situation where no treatment, no equipment, no surgery, no medications, no nothing can save your brother's life. That is a real end-of-life situation. The perceived end-of-life situation is just that. It's a perception. There's a perception that your family member can't survive. It's a perception, right? I don't know whether you were here from the beginning. Once again, I read out a testimonial from one of our clients who said, well, you've helped me save my sister's life because you helped me advocate. The intensive care team says she won't survive, right? And she did with the right treatment. Once again, that was a perceived end-of-life situation, not a real end-of-life situation. Knowing the difference between a real and a perceived end-of-life situation in intensive care is making all the difference. It's making all the difference. And if you don't know the difference, you are doomed. You are doomed. So now that you know the difference between a real and a perceived end-of-life situation, your question about can I ask for more time to make decisions and delay end-of-life support? It's not it's a good question to ask, but you shouldn't even be asking that question. Intensive care units are there to help save lives, not to kill people. Right? So I'm not sure why you are kind of suggesting that you're even considering asking more time. You should just be asking for what you want. Ask for what you want. One thing is for sure, if you agree for your brother to have end-of-life care and die, you know the outcome. You know the outcome. If you continue treatment, you don't know the outcome. There's a high degree of uncertainty. So by moving towards end-of-life care, there's a high degree of certainty that your brother is going to die, especially if he's on life support, right? Right? But if you continue life support and you give him a chance, maybe he will, maybe he won't improve. But if he won't improve, there's plenty of time to talk about end of life. Plenty of time to talk about end of life. Right? If you let your loved one die, if you let your brother pass away, right, you know the outcome. There's no return from that as far as we know. No return from that as far as we know. Think about that. Think about that. Right? So make a conscious decision here. You know, and what makes you even think that you can't ask for more time to save your brother's life? What makes you think you can't ask for more time? Are you so intimidated by them? Don't be intimidated. Ask for what you want. Full stop. Ask for what you want. Ask for what your brother would ask for. You know, that is what intensive care is there for. That is what doctors and nurses in intensive care went into, I would hope, to save people's lives. Right? Not to kill people. And also, God forbid, you know, if your family member can't come off the ventilator, you know, once again, there's services like intensive care at home now that might be able to help you get your brother home. Right? So I really hate when families in intensive care think they can't ask for certain things. What makes you think you can't ask for certain things? Where's that coming from? Where's that coming from? You know, you got to ask for what you want. Very, very simple. You got to ask for what you want and for what you know is right. You know, we can guide you here. We've been guiding families in intensive care for over 10 years with so many results, so many good outcomes. You know, we can do the same for you. Okay, next question from a subscriber, Mary, who says, "Hi Patrick, my mother-in-law had emergency open heart surgery during a tricuspid valve surgery and now is on a ventilator. That was on Tuesday. It's been 3 days since the surgery, so 4 days now, and she's still on the ventilator. But the doctor says she isn't ready to come off it. Any advice?" Yes, if your mother-in-law had emergency open heart surgery, i.e. for a tricuspid valve replacement or repair, that means her heart would have decompensated. She probably went into heart failure of some sort before she went into surgery. That is always risky, that is always tricky, right? And she would have had complications during surgery, whether that's her going into an irregular rhythm, VF, VT, AF, SVT, name any irregular heart rhythm. She might have sustained that during open heart surgery, and that would have delayed her waking up. She might have had a significant bleed during open heart surgery, right? That will definitely delay waking up. Another thing that often happens during open heart surgery, not in all cases, but in most cases, depending on the length of surgery, when patients have open heart surgery, they end up on a bypass machine, like an ECMO machine, for a period of time to stop the heart, right, so that the surgeons can operate on the heart. The bypass machine then is taking over the function of the heart, and it's also taking over the function of the lungs, right? And during that period, the lungs are collapsed, right? The longer the lungs are collapsed during open heart surgery, the higher chances are that after open heart surgery, there is a building up of atelectasis, which could lead to pneumonia, right? And so that complication could happen as well right now. Maybe she's got a pneumonia because during the open heart surgery, the lungs were collapsed for too long. And now she's, developing a pneumonia. What are the most common complications of the open heart surgery? There are irregular heart rhythms, like I said, VF, ventricular tachycardia, ventricular fibrillation, VF, atrial fibrillation, also known as AFib or AF, SVT, supraventricular tachycardia. Those are some of the most common irregular heart rhythms after open heart surgery. Sometimes it can be fixed simply with some pacing wires, pacing leads, right? Temporary pacing. Sometimes it can be managed with medications such as amiodarone, digoxin, electrolyte replacement such as magnesium and potassium replacement therapy, right? So those are some of the complications. Like I said, bleeding during surgery or after surgery, that might contribute to complications, right? And then your family member might need blood transfusions, might need blood transfusions, red blood cells, platelets, FFPs, to stop the bleeding. They might need to go back to surgery to stop the bleeding. Maybe, the best they can, stop the bleeding while they're operating, on it. Other risk factors are tamponade. With tamponade, I mean, after open heart surgery, there could be an internal bleed, but you can't actually see it. It's not coming out into the chest drains. And then there's a buildup of blood around the heart, and that could lead to cardiac arrest. So, hopefully that was detected soon enough. Maybe that is why she can't come off it yet, because she had to go back to surgery. She had to go back into an induced coma. That's delaying, waking up. Other issues that have happened during open heart surgery that I've seen, patients unfortunately sustain a heart attack. That might contribute. Other complications that I've seen is, an infection is building, whether that's a pneumonia, maybe blood sepsis, those are things that can happen after open heart surgery, delaying waking up, delaying your mother-in-law coming off the ventilator, right? If open heart surgery is elective, i.e. planned, right, most of the time patients go into surgery, come into ICU, get extubated within a few hours, and usually go back to a hospital floor or hospital ward the next day, right? Other things that can happen after open heart surgery, your mother-in-law has become hemodynamically unstable. So what that means is she might have, low blood pressure, high heart rate, or might even have low blood pressure, right? And she might now need vasopressors or inotropes, or she might need vasodilators, right? Either way, she would need intensive care therapy for that. Maybe that's why she's not ready to come off the ventilator. I don't know, without once again having all the details. So what you can see over and over again is that when someone is in intensive care critically ill, that it is a very complex situation, extremely complex situation. And with the complexity of the situation, unless you understand the details inside out, you're fighting almost a losing battle, because you don't really know what to look for, right? You really need to have worked in intensive care for long periods of time to understand the ins and outs, and like I say, sometimes I get questions from families in intensive care, and they're not even addressing 90% of the things that need to be addressed to answer the question, which is why it is so important that you get professional help. If you're not getting professional help, you're fighting a losing battle. Okay, so then next question is from Happy. Happy says, "Hi Patrick, my father had an unexpected stroke and the ambulance brought his heart rate back, and then at the hospital he had a pulse. My dad's sister signed a DNR and nobody else wanted to or even asked her. His sister shouldn't have even been offered the option to sign that paper, or was legally able to when he has two willing and able children. What is the law behind this?" Now, Happy, I am not a lawyer. However, I do believe you have a very good chance that as your father's child, that you can get power of attorney here. I'm very confident here. And no one should be signing a DNR without patient consent, right? Unless there is an advanced care plan. Okay, you haven't talked about an advanced care plan here, and once again, my question here is, what is the hurry? Where is the urgency to kill someone? Please explain that to me. Where is the urgency to kill someone? Where's the rush? Right? And I agree with you that your dad's sister should not have been given the option to sign a DNR. Absolutely not. But I also don't think it's too late for you. I think this can be reversed. I believe it's important for you that you seek advice, whether it's from a lawyer or from us. The way we would go about it is we would help you write a letter or an email to hospital management to make a complaint, right? I think it is only reasonable that you as a child, should be making decisions here and not your dad's sister. I don't know your family dynamics, but obviously you seem to have a higher interest in advocating for your dad's wishes than she does, right? And in that case, you should be the one making decisions. Now, I cannot talk about what the law behind it is, but I have seen it over and over again. And usually, with the right level of advocacy, with the right evidence, maybe you've got some evidence that your dad doesn't want his sister to be next of kin. I don't know. With the right level of, again, advocacy. And you might need some legal advice. You might. I'm not 100% sure, whether you need some legal advice here or not. And go from there. So then, next. Next question. This is just a comment from Gail. Hi, Patrick. Sadly, my husband passed away while in the LTAC in New Jersey. While he did have an infection, ultimately he couldn't keep his blood pressure up and he had 3 cardiac arrests on the 1st of November 2024. I think you have a good company and best of luck in your future endeavors, from Gail. Thank you so much, Gail, for that comment. Again, I'm so not surprised that your husband passed away in an LTAC in New Jersey. Why did he have an infection in an LTAC? And that would have led to his demise. That would have led to him having a low blood pressure, and it would have led to him not being able to, being resuscitated, because once again, LTACs, they can't do what an ICU do, and yet they're pretending they're looking to look after intensive care patients, right? So going to LTAC is really, really dangerous. Anyone watching this or listening to this, you should never ever agree to have your loved one go to LTAC. Never ever, right? You're only setting yourself up for failure, and you're only setting yourself up for substandard care for your family member. Very substandard care that can lead to patients dying, which is exactly what's happening here, right? Again, you can't start researching the topic of intensive care early enough. You just can't, right? The minute you are not doing research, your loved one's life is in absolute danger. Is in absolute danger, right? The minute you start underestimating that, your loved one's life is in absolute danger. So, constantly boggles my mind that, people don't get a second opinion when they have a loved one critically ill in intensive care. Constantly boggles my mind that this is what people do, or don't do for that matter. Our advice would have been not to go to LTAC in the first place. That would have been our advice, and that would have been the end of that. That would have been the end of that. Okay. And we have done so very, very successfully for many of our clients, keeping them in ICU until they were ready to be discharged. Until they were ready to be discharged. So, okay, so now, next question from Sabrina, who says, "Hi Patrick, I don't know when my mum will wake up, and the ICU doctor's wanting to send her to an LTAC facility." Right. Well, okay. Well, I don't know when your mum will wake up either at this point, but once again, it's a very incomplete question. Why is your mum not waking up? Why? Is she not waking up because she is still in an induced coma? Is she not waking up because she had a brain injury? Is she not waking up because she's simply critically ill? And that in and of itself can lead patients to stay in a natural coma at times. Right? So, yeah, those are the questions here, and ICU wanting to send her to an LTAC facility. So two things to avoid an LTAC. The first thing is, do not give consent to a PEG tube, right? That's number one. Number two, another reason or another way to avoid LTAC is, can your mum avoid the tracheostomy? Because if she can avoid the tracheostomy, what are they doing to avoid the tracheostomy and get her off the ventilator? Right? Have you asked that question? The minute your mom has a tracheostomy and a PEG tube, chances are she will be going to an LTAC pretty quickly. Right? Chances are she will be going to an LTAC pretty quickly. You don't want that. You don't want that. Avoid LTAC at all costs, just as much as you need to avoid, the ICU team making end-of-life decisions that you are not in agreement with. You need to avoid all of that, full stop. Okay. Moving on, and moving on to the next question. And also lastly, another reason or another way to avoid LTAC is simply getting access to the medical records. We can look at them, and then we can help you challenge any decisions they want to make to send your loved one to LTAC. Again, with our consulting and advocacy, we are getting results, right? We are getting results for families in intensive care. And that's the bottom line. We've got podcasts on at intensivecarehotline.com where our clients verify that we help them to avoid LTAC with much success. Right? Just got to know who to talk to. All right. Next question is an intensive care at home question. I actually spoke to an inquiry this morning, and there's a family who's got their mother in ICU with motor neuron disease, and before going into ICU with pneumonia, she was at home on BiPAP, right? And she was at home on BiPAP and then aspirated, and now she's in ICU with pneumonia. She needs a tracheostomy, and she also needs a PEG tube. Now, in this situation, if someone is having motor neuron disease, right? If someone wants to prolong their life, they should actually have a peg and a tracheostomy. There are exceptions to the rule. And this is why I keep saying over and over again that, you know, ICU and intensive care is so nuanced. You know, you need to be able to compare. You need to know it's not a one size fits all. It is absolutely not a one size fits all. So the reason for the inquiry this morning was that the family wants to have intensive care at home. They want to have intensive care at home services, and you know, we can help them with that. You know, we can help them with that. And that leads me that with intensive care at home, like I said earlier, we are sending our critical care nurses into the home, predominantly for long-term ventilation and tracheostomy, but also home BiPAP, home CPAP, without tracheostomy without ventilation, home TPN, home IV potassium, home IV magnesium infusions, ventilation weaning at home, central line management, PICC line management, Hickman's line management, and port catheter management. And we're also providing palliative care at home. We are operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are an NDIS approved service provider all around the country in Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, and IISQ in Queensland, and also the DVA all around the country. We're also providing level 2 and level 3 NDIS support coordination for our clients, and we're also providing TAC and WorkSafe case management in Victoria, or for WorkSafe and TAC clients in Victoria. Now, with Intensive Care Hotline, you know, go to intensivecarehotline.com, where I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly, and I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. I also talk to doctors and nurses directly, and when I talk to doctors and nurses directly, I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time, and we also do medical records so that you can get a second opinion in real time. And we also do medical record reviews after intensive care, so that if you, in case you have unanswered questions, if you need closure, or if you are suspecting medical negligence, and all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. And if you like my videos and if you like this show, give the video a like, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell. Comment below what you want to see next, what topics do you want me to cover, or what questions and insights you have from this video. I do these weekly YouTube lives, usually on a Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is currently 6:30 p.m. Eastern Standard Time in the US, North America, which is 3:30 p.m. on a Saturday, Pacific time in North America. So I want to wrap this up here very soon. Also, keep in mind, we're also providing level 2 and level 3 NDI support coordination for our very vulnerable clients, you know, and if you have any questions, just reach out. The quickest way for you is just to give us a call on the numbers on the top of our websites at either intensivecarehotline.com or intensivecarehome.com. Our respective email addresses are support@intensivecarehotline.com, or send an email to info@intensivecarehome.com if you want to inquire about home care. Thanks again for your support. Share this video with your friends and family so we can help as many families in intensive care as possible. Thank you so much for watching. This is Patrick Hutzel from intensivecarehome.com and intensivecarehotline.com, and I will talk to you during the week with my quick tip videos and also next week on the live stream again. Wishing you a festive season as well. Take care.